Patient Forum, to thank the Health Management Association to support us in this process. We have quantitative data from 124 healthcare organizations throughout the European Union, and we are currently analyzing them, Christina from EPF and ourselves from EFN. I have 2 slides on them, and I would like to take these slides, make a link between what we theoretically know, but what we also have to have from qualitative data. And therefore, this webinar is very important. Graphs and signals and tables is one thing, but you also need to go to the field. And we have put a program together going to that field. We don't need the highest people in the hierarchy to talk about what is going on in the field. And therefore, we are great to have Monica from Romania with us as a physician who has worked a long time on this, but also the patients. Giulietta is with us, and we really appreciate the patient's view on this. Of course, you cannot, the healthcare organizations, we have data from 124 healthcare organizations who are joined and linked up with the joint action. This is an enormous capacity, and we are grateful that you are looking at the implementation on processes, on tools, and to share this with the field workers, because we can have nice ideas, but if the field workers, if our colleagues, nurses, physicians, patients are not picking it up, what is the sense of doing this? And so in that sense, I also want to thank Stephanie and Michael, and then our colleague from Spain, Jose Luis and Rafael, for joining us, and then Milena and from Bulgaria, and Hannele from Finland. Now, I want to stress that in setting up the agenda, we are very lucky to have some Eastern European countries out with us. This is crucial for us. It is not only the West to the East, it is also about the East giving their experiences, especially in times after austerity, to share their good things with us. And therefore, I'm extremely grateful to have you. But finally, I want to stress also the input from the pharmacists, and Stephanie and Michael from Northern Ireland were so kind to join us. And I know that PGU is also with us online, but I have also a student with us. I find it very important to have the young generation with us, to have their different views on this issue and see how their studies, how their stages and daily reality on this topic is developed. So I'm grateful to have Faber, who is sitting next to me, with us. Finally, my thanks goes to Microsoft, and Ray is with us also from Paris. We are quite lucky, to be honest, to being able to come to these Brussels offices. We have Marta with us, we have Alain with us. I mean, this technical support, we would not be able to do it. I would not know how to start with it. And so we are very grateful for coming to these offices and using these offices with the highest technology. So Ray, thank you for your support, and also you will have address. It is important that next to the patients, the healthcare professions, the industry who produces these tools is with us also. And in that sense, I don't know if Monica from Monica Haras has joined us in meantime. Do you know, Anna-Marie, if she joined us?
She has joined.
She joined. Monica, do you hear us? No, not yet.
Maybe she's muted, Mark.
No, I have no idea.
We wait a moment. Monica, do you hear us? No. Can I show 2 more slides, and then we can move on. This is a slide I want to show you on medication reconciliation, which comes from the questionnaire that the member states are filling in, have filled in the first measurement. And you can see the 3 levels of medication reconciliation process. And you see the bars. In total, we have 124 healthcare organizations implementing medication reconciliation. It shows the good things we have. You see that fully implemented is the green line. But you see also the blue line, not at all implemented. So it is important to show that we still have a long way to go. Next slide, please. And here, what is important in this slide gives you some percentages, and these data will be shared in 2015 when the full report is finished. But what is important in this slide is the engagement of the patient, the engagement of the social care workers, the engagement of the carers in that entire process. And so there we can have some views on discharge of the patient, because discharging the patients from one setting to another setting, there you can see that 37% of those who answered are in that way already. And this is quite positive results, I get the feeling, but we still need to do more. Look at 4 patients and their carers and families are handled out informatics sheets and points to consider. 15%. So if we talk about patient empowerment, patient engagement, let us identify these gaps and let us work on it together.
Dispozitivul produce o calitate audio.
Okay, Monica?
Can you hear me?
I can hear you very well, and I think the colleagues outside there also. Monica, I'm very pleased because you were the first one on the program, and if you feel comfortable, I can give you the floor now because I have done the introduction already. Is that okay for you?
Thank you very much for inviting me here. Is it still okay? Do you hear me?
Very well, Monique.
Okay, thank you. Thank you very much. I am honored to be invited here. I am a physician as my basic work, so I'm going to share with you the point of view of a physician. My work field is rehabilitation, which is a post-acute care in Baghdazar Arsen, Bucharest. And I will give to you a few examples that I have met in my daily practice about the importance of medication reconciliation. Since the site of medical care often coincides with a change in the patient pathology, and this happens very much in my clinical setting because we get patients who had car accidents or strokes, and we take them from neurology or surgery. And of course, the medication changes along with the course of the patient's pathology. So the point is we have to be fully aware about the previous medication, the patient's history, and to reconciliate while adapting it in full knowledge of the patient's current state of health. Well, the process of data collecting may be easy in large hospitals where patients generally have an electronic chart which includes daily medication. So I can see what my colleague from another clinic, let's say a surgeon or a neurologist, has given to the patient I took in my care yesterday. And it's very easy to follow the course of medication, but when I take a patient, for example, a Romanian person who has been injured in Italy while vacationing, or a person who had an accident in the countryside while vacationing, I have a problem following the course of medication that patient has been given. So it is very important to try to thoroughly collect data about previous medication using the interaction with the patient, with his family. The nurses are important because sometimes they get some extra information from the family or for the patient that the doctor hasn't been able to get because of their short interaction, their short dialogue. Also, the pharmacist and doctor-to-doctor communication is very important, especially when the patient is transferred between medical units that are very far apart, and the written discharge papers are very important.
Monica, do you want us to continue with the slides that you have? Do you see your slides on the screen?
You want me to put the slides on the screen?
No, we have your slides on the screen. We have them already. Do you want to follow them?
Okay. I have a bit of a problem here with my...
Okay, no problem.
A few short examples are antihypertensive medication. For example, patients who had a stroke are generally previously hypertensive patients, but it's not a rare circumstance that they become hypotensive, so the medication has to be adapted. Again, the process of medication reconciliation should be combined with careful patient monitoring. Can you excuse me for just a little? I'm in the hospital. 2 seconds. Okay. A very important part of therapy that needs reconciliation is anticoagulant and antiplatelet medication, because most of our patients, for example, receive anticoagulant or antiplatelet medications for various reasons. And when a complication occurs that requires surgical intervention, we need to communicate and to take into consideration the surgical risks and to communicate with the surgeon to inform about the course of treatment the patient has been receiving, to minimize the risks of emergency surgical intervention, so that our colleague, the surgeon, can take the necessary precaution measures to minimize these risks. Antibiotics always need reconciliation because it's a great danger if I introduce new antibiotics to a patient who's already taking a certain drug. I will select resistant bacteria, I will produce dysbiosis and many complications to the patient. So again, communication between doctors and pharmacists, doctors and patients, nurses is very important. So the course of therapy is adequate as a duration, dose, and type of medication. These were just a few examples of widely used medication that need reconciliation when changing the site of medical care. In our experience, medication reconciliation is of paramount importance, especially when the patient is moved from the acute type of care units to chronic or post-acute type of care units. So that would be all.
Thank you so much, Monica. First of all, I thank you because I realized that in your working situation, in the hospital you're now, you have to do these two things. And on one hand, this webinar, but on the other hand, the work continues while you're speaking. And we really appreciate that you take this time with us to share the Romanian experiences. This is really highly appreciated. I would like to hand over to Febe de Koene, and who will present herself. Febe, the floor is yours.
Hi, I'm Febe de Koene. I'm a pharmacy student at the University of Ghent, where I'm finishing my master's degree, and I'm thinking of a PhD next year. I am also an SND politician in my local government, and I'm currently conducting interviews with elderly on medication reconciliation as a school assignment. This assignment is a research study to receive insight on the medication use with elderly. This study runs from January until May 2014, where every student at the University of Ghent in his master year needs to interview 6 older people, so this gives a total of 900 subjects. We need to take a look at their medication history, and based on this, we need to check 5 lists with inappropriate medication for the elderly. I will discuss a case I came along during this interview. Based on the analyzing of the medication history available in the pharmacy and an updated interview of this list, we concluded that the patient explained that she was taking alendronate together with calcium. Calcium, however, inhibits the uptake of alendronate, but both medications were prescribed and needed, so we needed to inform the patient that she needed to take the medication on 2 different time periods. But you cannot underestimate your patient, as explained in the following example. During the interview, the patient needs to remember 3 words, draw up a clock, and then say again the words. She insisted that the words were in the right order, so she was still clear to mind, however she was 74. The outcome of this study is to see whether this procedure is achievable in all community pharmacies to evaluate the MR of older people. During the 5 years of my studies, bachelor and master, I have not heard of the concept of medication reconciliation. It's not permanently present in the courses. There are some reference made to evaluation lists for medication use in elderly, but not in detail discussed. For my opinion, there is more need for interdisciplinary teaching. Pharmacists should sit together with doctors and evaluate some medication issues which can occur at the pharmacy and how to react on this. The pharmacist should be regarded equal as a doctor in these situations. The pharmacist can now not intervene as pharmacists when they see something is wrong with medication. They need to intervene a doctor. Currently at the University of Ghent, there are some PhD students and professors conducting research on drug-related problems, but not specific on elderly. There are only a few studies. However, the elderly are a growing group of population, so it's necessary to conduct more research. So that's my opinion as a student.
Thank you very much, Febe. It's really a pleasure having the students' voice, especially from the community pharmacist where you're working now, with us. And I really hope that the students pick this up. It's also very interesting. We have a European Directive 55 where these issues, curriculums are discussed, and it's also interesting for the European Union to see how medication reconciliation is interdisciplinary taught. I would now like to hand over to Stephanie from Northern Ireland. Stephanie, the floor is yours.
Thank you very much. Thank you for asking me to speak today. I want to tell you about the medication reconciliation process, which is performed in the Northern Trust by the pharmacists. The process is performed at transition points, especially at hospital admission and discharge. There are current guidance on admission, and in particular the role of the pharmacists. The Safer Patient Initiative, which involved Institute for Healthcare Improvement, IHI, states that 95% of patients should have a med-rec performed within 24 hours of admission, while NICE in 2007 guidance said that pharmacists should be involved in medicines reconciliation as soon as possible after admission. We also have regional Northern Ireland clinical pharmacy guidance and standards on med-rec. The Moving Patient, Moving Medicines, Moving Safely document produced in 2005 by the Royal Pharmaceutical Society of Great Britain, along with others, states that the number of errors, omissions or alternations were found to be considerably lower on pharmacists' written discharge prescriptions, 8%, than those written by junior doctors at 32%, and a higher proportion of the patient's own drugs were considerable for reuse at discharge. Next slide.
Stephanie, everybody speaking in between.
Hello?
Please, participants, for those not speaking at the moment, mute yourself because we can hear you.
I think I have muted. Stephanie?
Yes, hello.
Thank
Okay,
you. Sorry, Stephanie.
we have cleared it out. Because
Okay.
otherwise it's not 100% clear if 2 or 3 people are talking on the phone.
Yeah. Do you want me to redo that slide again? Or
Absolutely,
Yes, please.
absolutely.
Yeah, sorry, MedRec at discharge. Their document called the Moving Patients, Moving Medicines, Moving Safely was produced in 2005 by the Royal Pharmaceutical Society of Great Britain, along with others. And it states that the number of errors, omissions or alternations were found to be considerably lower on a pharmacist written discharge prescription at 8% than those written by junior doctors at 32%. And then the higher proportion of the patient-owned drugs that they've brought in from home were considered suitable for use at discharge. Sorry, next slide. So pharmacists, on the basis of this, then pharmacists within the Antrim Area Hospital here within our trust write the majority of discharge prescriptions. The pharmacists are mostly independent prescribers and we've started to roll this out to highly trained pharmacists, transcribers who use protocols to transcribe the discharges. And this is currently being rolled out to our other hospitals within the trust. Sorry, next slide. Whilst the MedRec process has been implemented for a number of years, it was done so as a paper-based system, which has a number of disadvantages. The details may be recorded in different formats by different users, especially handwriting and spelling. Transcribing errors may occur if the information is then taken from the MedRec form for use in other documents, such as discharge prescriptions. The long-term storage of paper records can be problematic, and then getting access to these records can be difficult, especially at night, and particularly if the patients move to different healthcare locations. Sorry, next slide. So to solve these issues, the Northern Trust developed an electronic solution, and we did this in a local innovation partnership with Yara Software, based locally in Belfast. To do this, we did small tests of change to develop the system, and we incorporated significant feedback from the users, and this has led us to using phase 2 of the system. We are live since May 2013, and we're live throughout our whole trust, including our mental health hospital and some non-acute hospitals. We're approaching 20,000 MedRec records within the system as well. The software we use is a web-based program, and it interfaces directly with the Trust's patient administration system, which gives the patient demographic and ward information and admission dates. We also interface with the NHS Drug and Medical Devices Dictionary, the DM+D, and that gives us a standard dictionary for drugs. We also have an Epics pharmacy intervention recording system, which interfaces with it as well. And the system has a query database, which allows us to in-depth analysis of the patient, their medication, and the pharmacist's involvement. The advantages for the electronic MedRec system are that we're getting real-time updates from the patient demographics by the Trust PAS system. The medication details are standard and they're taken from the DM+D dictionary, and these are clear and concise. The patient's MedRec information is retained within the system indefinitely, and the MedRec is available to any user of the system at any location at any time. There is real-time recording of the intervention on completion of a MedRec or a discharge, and that's automatically populated into the Opis intervention system. The discharge medication list is then pre-populated from the completed admission MedRec. Once this list has been verified, the information is printed as a discharge and is exported into the immediate discharge summary, which forms part of the patient's discharge information for the general practitioner. The general practitioner then gets a complete list of the medications, including any changes to the admission medications, and it is then indirectly available in a single patient electronic record, the ECR, which is available to all healthcare professionals. The next time the patient is admitted, the next MedRec is populated from the previous admission medications, either from the discharge or the admission, and then that is used for the basis for the next admission. We're also piloting portable handheld devices which can be taken to the patient's bedside, with the view of all clinical pharmacists having access to one of these devices, regardless of their ward base. And this slide shows an example of our MedRec system. The left-hand side shows you the admission. So you get the green banner, you get the patient's demographics. It also gives you the medication name from the DM plus D. We have dose, frequency, and additional frequency comments. Route of the medication and the status of the medication, so whether it's continued, held or stopped, etc. And then whether action is required for medication by a pharmacist or doctor. And then also when the medication has been reconciled at that time. And then any comments about the medication. Sorry, can we go back a slide? Yeah, thank you. We can also make general comments about the patient's admission medication or any requests for follow-up by any other healthcare professionals. We also record main details about the hospital stay and about information where we get our information sources, so whether it's from the GP list or from the community pharmacy. Lab test results are checked as part of our process for MedRec, and they're added to the report, and we would only bring over the abnormal results. Once the MedRec is completed, the stage is then updated to MedRec complete, and the admission report can be printed, available to be viewed, and then we can print that for the doctors or nurses. The right hand side of this screen shows you then the discharge list, and this is then updated as compared to the admission, and explains any changes from the admission medications. Once this has been verified, it's printed for the GP and is exported into our immediate discharge summary, which is then available. Sorry, my screen has just gone. Which is then exported to the electronic care record for the patient. We can also print out a patient medication record as well for the patient to take home with them. If the patient has been in on several occasions, we can view previous admissions as well, their medication and discharges list. Sorry, next slide. And then this is the immediate discharge summary, the medication portion, which the general practitioners receive by the patient on discharge. It's sent out to the primary care physicians, especially the general practitioners and nursing homes. It gives all the patient details, GP details, patient demographics such as address, any allergies or sensitivities. And then it gives the list of medications, which again is technically used in standard names, dosages and frequencies. Any changes to medications, admission medications are explained, including new medications which have been started in hospital and the patients to continue on. And then we have a separate box on the right hand side that I've highlighted in red that shows any stopped medications, any withheld medications, So they don't come on the main medication list, but are highlighted for the general practitioner and the reason for that stoppage or the held. And also then we can explain any differences. So again, in the red, we've explained that the medication has been stopped because of, for example, patients starting a new anticoagulant. And then we also asked for any follow-up recommendations from the primary care professional. We have the access to do that. And that is a very quick summary of what we do. Thank you.
Thank you so much, Stephanie. This is a good example of a best practice in the European Union. It should be picked up in one way or another by the joint action, because the purpose of the joint action is to exchange best practices between regions, between member states, and I think many people in the European Union would be loved to have your experience and your take-up. Let me also say... Yes? Okay. Let me also say, Stephanie, to thank Dr. Scott and Marina Lipari for bringing me in contact with you for this brilliant presentation. Thank you so much.
Okay, thank you.
I hand over the floor then to the next speaker, Ray Pinto from Microsoft. As I told you, I think it's very important to have the industry view on these developments, medication reconciliation, and I'm very pleased that the industry has an example on this topic. Ray, I hand over to you.
Thank you very much. Can you hear me?
Absolutely, very well.
Okay, I think I need to just quickly begin my presentation by apologizing to those of you who can't seem to get the technology working. I'm assuming that it's probably a simple solution, but for this call, it probably won't work. I do ask you to please reach out to Marta. She can walk you through and fix those issues, so the next time you won't have one, we hope. So speaking of technology, what we're going to, well, at least what I'm going to cover very quickly, is just to kind of give a glimpse as to how can the technology help with you as nurses. Stephanie, your presentation was very compelling. Here is a great example of technology that can help nurses to have the transparency needed to understand the patient, what is the patient receiving in regards to medication, what is stopped, what is continuing. Fantastic. What I'm going to be highlighting is focused towards the patient themselves, and what does the patient have in being able to control and understand their own technology, and to understand their own medication history, and put it in a confined area, if you will, an area that's safe and sure that they can share and help others. Now, a lot of what I'm going to be talking about today exists primarily in the United States. And so why does it not exist here in Europe? Well, we have versions of it, very light versions of it in some countries, but because of existing data protection and privacy rules across the member states, it is very difficult to roll out the sharing of information, especially sensitive medical information, as you can imagine. And I know the European Commission is addressing this. I also encourage you, I'm just going to send this by link here. I hope that works. On YouTube, we have a video called Future Vision. And if you write Future Vision Microsoft Health, you can see what the next couple of years will look like. The video was actually done a few years ago, and some of the technologies that you'll see in there have become a little bit old school. And I'm sure in probably the next 3 or 4 years, all these technologies will come into being. So what is the different drivers to make this work? essentially, what Health Vault was trying to look at is you can consolidate your health data information into one secure enclosed space that lives in the cloud. This space would then be visible to you. It would be shared to those of you that you would believe is a safe care worker. You could open it up temporarily. You could open it up for longer periods to care workers that you need. And it allows the interaction between that data to be analyzed and processed. And I'll get into a little bit more detail on kind of how that works. That little picture that you see.
Esta es la conferencia, lo que pasa esta está en inglés.
Ah, hola. So that picture that you're seeing at the moment is essentially kind of what the future can look like. We have demonstrations of this using a mirror, for example, where you wake up in the morning and it lists on the mirror the medication you're supposed to take. In this example, there's two medical bottles. They both look green. And, if you're like me, an aging person, you tend to forget what you're supposed to do. The surface lights up. It says green. You need to take this now. So the person takes it and then puts it back. The RFID tags within the bottle knows that a couple of tablets have been taken, the right amount, no more, no less. And then the circle turns red saying, do not take this. So, these are the type of technologies that exist today, either in a very simple form, an SMS, on your website, on a mirror, on something you understand, on a timer, on some kind of screen that you have at home, that someone of hopefully any different age group can understand. And two, this kind of future vision where you have interactive surfaces. So if you just go to the next slide, please. And Paul, please tell me if I'm talking too much, which I tend to do.
No, you're on time. I'm registering it. Don't worry.
I can see your face, so I know I can see the reaction. Oh, speaking of which, I turned off my camera. So there you go. Unfair. Okay, so now this slide will allow again, it kind of talks about what we're talking about, what I mentioned in the beginning. In a little bit more depth, what you want is that what we experience, at least, especially for getting medical treatment across different areas, is that the information, or different doctors, you're doing pathogens or blood samples in one group, you check for diabetes with another doctor, you got another test or treatment in another hospital. This is the core of the discussion today. All that information becomes stored into one place. And that allows you to share the information. With who? Besides your care worker, you can also share the information to be looked at and tracked by maybe someone within your family. It could be your family's data records that are stored, within one specific space. I live in France. I don't know if there's a nursing association from France. I know that they are trialing a type of technology very similar to this, where you can store your information. I have yet to on the phone. I am not a doctor. I barely passed with my bachelor's of political science. So how am I supposed to understand my cholesterol levels, my heart condition, and all the other, scribblings on my medical records that just don't make sense to me. This is kind of where some applications can come into play. If you can go to the next slide, please. Thank you. Some of the information can come into play where it becomes a lot more simple for me to understand the prescriptions that I'm getting. It allows me to, it interprets for me what that means. there are some websites going up there that allow the evaluation of prescriptions. So if I'm given a prescription from someone and a doctor that I haven't seen or from somewhere else, and I want to just check it, I want a second opinion. You always want a second opinion on anything. That could be analyzed with this application, and the application can pull the data and then realize, oh, well, do you know you've been diagnosed with this form of diabetes from this other doctor in this other region, and actually if you take this this prescription, it might cause some serious harm. So this is the type of thing that allows the patient-centric control and care to come into play, and that data availability could be given to a nurse, where I can maybe try to get that second opinion from a nurse who's kind of monitoring over a whole wide range of different treatments that I'm getting for different types of issues. So we can go to the next slide. Thank you. And the other thing that it allows you to do is to be able to track, or the care worker, I should say, to be able to track the treatments you're getting. And a lot of this can be done over the line, so over an internet excuse me, an internet line, or from distance treatment. You'd be able to get information coming in. The algorithms might even see that something is not quite right, and then trigger a message over to a family member or to a nurse or a care worker. You would have a discussion, as we are having now, over the internet. If you feel it necessary, call the person in or go visit the person, and be able to monitor treatment over a distance. So that's just a kind of very quick overview of what these technologies are coming into play. Obviously, there is a lot of policy and regulatory issues that need to be looked at for these technologies to hit the market. The industry, especially ours, need to work with other parts of the infrastructures across many different countries to ensure that you have broadband, ensure that you have internet no matter where you live, ensure the technologies work, and no one on this call would have any issues. It worked very well. So as these technologies mature, as the policy and regulations understand the technologies come into fore, and as care workers understand how to use it, and there's some cultural mind shifts, then I think they'll start delivering some benefits that will help everyone.
Thank you very much, Ray, for this presentation. You're exactly on time. You used your full 10 minutes. I know I have been very strict on all the speakers for staying 10 minutes, but up till now it worked perfectly. I would now like to hand over to our Spanish colleagues, and Jose Luis, I hand over the floor to you.
Okay, thank you very much from Spain, from the Spanish General Council of Nursing. I'm Jose Luis Cobos, I'm nurse, and here is with me Rafael Chirquet, is nurse too. I'm sorry, but I prefer speaking Spanish, so Carlos de Lecea is my translator, so let me speak in Spanish. Okay. Bien, nosotros partimos de una experiencia en España tras la modificación de la ley del medicamento que ahora permite a las enfermeras prescribir. Ese es el punto de partida que les quería comentar.
The starting point of what I'm going to explain to you today is the amendment of the law on medicines in Spain.
A partir de ahí nosotros hemos realizado un programa de formación para las enfermeras para adquirir esta nueva competencia, y les presentaré hoy una herramienta que hemos utilizado para apoyarnos en ello, que es e-cuidados.
According to the new law on prescribing, nurses were authorized to prescribe, so we set up a training program for nurses by using a platform which is called eCuidados, that is e-care in English.
Debemos recordar que la enfermera es en muchos casos el primer punto de encuentro de los pacientes y por lo tanto va a ser un punto fundamental y eje de contacto entre profesionales.
Keep in mind that nurses are very often the first contact point that patients have, so she's a kind of point of contact and coordinator between the different professionals.
A través de esta herramienta de cuidados, lo que vamos a intentar es facilitar la toma de decisiones por parte de los profesionales sanitarios, facilitar el trabajo del equipo multidisciplinar y también facilitar la autonomía del paciente, sobre todo los pacientes crónicos y polimedicados.
Through this platform, through this e-care platform, we aim at facilitating the decision-making, multidisciplinary work, as well as patient autonomy, especially in the case of chronic patients and in the case of polymedicated patients as well.
En resumen, podemos decir que esta plataforma lo que va a ofrecer es seguridad, tanto a pacientes como a profesionales, trazabilidad, que me ha gustado mucho que Ray hacía referencia a ello, queda registrado todo lo que el profesional hace y la medicación que se tiene que tomar el paciente. Y es interoperable entre distintas plataformas, permitiendo que pueda ser utilizado tanto en atención primaria como atención especializada.
So this platform provides safety for the patient and for professionals as well, and it provides a traceability too. I really like Ray mentioning the issue of traceability. So therefore, thanks to this platform, we can know everything about the medication, and the platform is also interoperable. That is, that it can work in primary healthcare as well as in specialized care.
Next slide, please.
Next slide.
Además, esta plataforma lo que va a incorporar es todo el conocimiento enfermero de cómo hacemos nosotros la atención al paciente a través de nuestra metodología, nuestro lenguaje. Lo que hemos incorporado son 200 planes de cuidados, guías de práctica asistencial enfermera y 1.100 procedimientos y protocolos que nos ayudan a estandarizar el cuidado.
We have also included in our platform all nursing knowledge for the patient. That is our methodology, our language, including 200 care plans and 1,100 procedures and protocols in order to standardize care.
Acompañando a esto, hemos incorporado todo el ámbito del medicamento y los productos sanitarios, un total de 80.000 en total, que nos permiten controlar la medicación que está tomando el paciente en cualquier momento y vincularlo con la atención enfermera.
We have included 80,000 medicines and healthcare devices so that we can check medication at all times and compatibilize everything with the nursing care.
Next slide. En estos momentos ya tenemos incorporada la aplicación en un sistema móvil que puede ser visto a través de iPad, de cualquier teléfono o incluso en entorno web.
We have a version for mobile devices, that is iPads, telephones, or even on the web.
Next slide. Ahora podemos ver cómo la enfermera a través de esta plataforma puede visualizar todo lo que es el lenguaje enfermero y toda su metodología, con planes de cuidado, como decía, guías, que ahora les pondré un ejemplo.
So, as I said at the beginning, nurses can see everything that is happening with the patient using nursing language and methodology and with guidelines. So, we'll give you an example very shortly.
Next, please. Esto que van a ver ahora es un plan de cuidado donde se incorporan los diagnósticos enfermeros con todo lo que tiene que hacer la enfermera a través de sus intervenciones, que irá acompañado a continuación con la medicación. Ya les digo que ahora en España las enfermeras pueden prescribir, pero no solamente incorpora la medicación que prescribe la enfermera, sino todo el plan de medicación que tiene el paciente.
So here we see an example of a care plan that includes the nursing diagnosis and the intervention. So that is everything that the nurse has to do with the patient, including the medication the patient has to take, not only the one prescribed by nurses, but the one prescribed by the rest of the healthcare team.
Debemos recordar que el término de reconciliación va muy parejo al término de adherencia al tratamiento, y eso es lo que nosotros conseguimos a través de nuestros planes de cuidados, que el paciente tome toda la medicación y en el momento en el que corresponda.
The term of reconciliation is very similar to the term of therapeutic compliance. That is that the patient has to respect the care plan and take all the medication at all times.
Have a problem. Maybe. Hello?
Yes?
I'm sorry?
It's okay, continue, Luis. It's okay.
Next, please. Por lo tanto, ofrecemos al profesional toda la información. Lo que están viendo es información de la vinculación del medicamento al plan de cuidados enfermeros, donde puede rescatar toda la información sobre un medicamento, toda su ficha técnica, todos sus problemas que puede tener en cuanto a interacciones, es decir, toda la información técnica que necesita para controlar bien la medicación.
So we provide all the information regarding the medication and the care plan. There are leaflets and all possible interactions and side effects of different drugs taken by the patient.
Finalmente se obtendría un informe que se le da al paciente de cuándo tiene que tomar la medicación, en qué momento y qué tipo de pastillas son.
In the end, the patient receives a report indicating the medicines he or she has to take, and which pills we are talking about, and the dosage and everything.
Next, please. Por lo tanto, en conclusión, les puedo decir que la plataforma de cuidados hemos comprobado que es una herramienta útil para la práctica profesional enfermera desde un punto de vista ético, autónomo y competente, y que permite la reconciliación de la medicación, proporcionando seguridad a los profesionales y a los propios pacientes.
So, in conclusion, we can say that the e-care platform is a useful tool for an ethical, autonomous and competent nursing practice, allowing medication reconciliation in a safe manner for professionals and patients as well.
Como dato les podré decir que en estos momentos en España somos 260.000 enfermeros, que este programa de formación para incluir la plataforma de cuidados en la práctica habitual lo han recibido ya 125.000 enfermeras en 3 años, por lo tanto se está haciendo un gran esfuerzo para concienciar a la enfermera del buen uso y manejo de la medicación y de la gestión de las buenas prácticas.
Just to give you some data, in Spain we are 260,000 nurses, and out of these 125,000 have received training on the e-care platform in 3 years' time. So we are raising awareness on the good practice of the platform and on the importance of medication reconciliation.
Terminar diciendo que estamos convencidos de que la enfermera en cualquier país es el eje fundamental para la reconciliación y un punto fundamental, el empoderamiento del paciente, puesto que tiene una gran labor en cuanto a la educación para la salud y por lo tanto creemos y estamos convencidos de que es una figura fundamental en este ámbito.
We think that the nurse plays a key role in medication reconciliation as well as in the empowerment of patients, because this way everything will be done much better in a safer way.
So thank you very much.
Thank you very much, José Luis. It was really nice hearing the Spanish experience, and you have still time left. You have spoken in Spanish and in English, and even within the timing. So thank you so much for this. And in that way, I really hope in the joint action with the Spanish examples that your example for such a broad spectrum of healthcare professions, nurses, are that this example is shared in other member states. There are opportunities within the joint action to do that, and also within the developments of other EU projects. I think it is very important to because it's not only about one or a single case. You are covering almost the entire workforce of nursing where others could benefit from. So I really would like to congratulate my colleagues in Spain for this presentation. I would like to hand over to Milena. Milena, are you with us?
Hello?
Yes.
Hello?
You can start your presentation.
Hello? Colleague?
Yes, Milena, you can start your presentation.
Milena.
Milena,
I have
you
a
can
problem.
start your presentation.
Milena. Antibiotic program case in Bulgaria. Listen me?
Yes, absolutely.
Absolutely. Dr. Bobcheva at this moment is absent because I lead the programs in this time and little early. Why can't our on hold to be included? Maybe of discussions. The main objective of the program is to improve the quality and safety of medical health by reducing the speed of antimicrobial resistance using pharmacoeconomics approaches in treatment and prevention. Those patients are provided optimal antimicrobial therapy and prevention. Antimicrobial agents are used for treatment and prevention and infections. Often the antibiotic therapy ineffective because of the vast increase of the relative share of polyresistant microorganisms and infective pathology, as well as patients with disbalance and immune response. And positive causal connecting has been proven between the use of antibiotics and the formation and selection of resistant microorganisms. The policy on antibiotics is determined by a commission of drug policy created by an order of director and is approved by director, updated annually and included goals, tasks, organization of hospital structures, hospital pharmacotherapeutic commissions, visiting microbiologists, clinical microbiology collegium, main components of the antimicrobial therapy with a choice of antibiotic types of antibiotic therapy, specific empirical and antibiotic prevention, but of introduction anti-antibiotic dose and dose interval, duration of therapy, side effects, interaction with other drugs, antibiotic combination, microbiological test, cost of treatment. The most profound change in antibiotic treatment is the cold switch therapy, early shift from potential to oral application on the antimicrobial agent, which ensures for optimal effect, reducing the risk of resistance, formation of in bacteria, and the cost for antimicrobial treatment. And antibiotic list with group of antibiotic treatment is prepared by all doctors in the hospital. Thus, with limited application by the head of respective department, their prescription is recommended after a microbiology test. Antibiotics requiring permission as prescribed by the head of department after microbiological test and etc. pathogen. So many importers in 2 steps of systematic process of intervening the patient's family and verification of this information with at least one reliable source. Also very important patient interview, testing of contract for delivery of medicaments. The antibiotic program applied to all departments and the 4 multi-profile hospital for active treatment, Sofia. It is mandatory for all hospitals in Bulgaria. Patient complete informed consent. If the patient is in intensive care, cannot discuss it, but on the other cases, be informed of the change of therapy. He states the reason that aims to better his treatment. Patient and interaction between patient, doctor, pharmacist, nurses, and other part the success of the strategy and reconciliation commission and drug policy manual. Also very important, patient interviews, tracking to context for delivery of medicaments. The antibiotic program applied to all departments and the 40 multi-profile hospital for active treatment, Sofia, leads Dr. Stefanka Bobcheva. In terms of patient care, stewardship programs reduce the use and intensity of antibiotics and are not associated with higher infection rates, longer patient length to stay, or worse health outcomes. Organizations of the function conducted under the rules of organization, operation, and under regulation of the hospital relevant departments and hospital pharmacy, and as well on the rules of functioning and the Committee on Drug Policy approved by Executive Director. This Act regulation, the rules for ordering, storage, and the dispensation of medical products. Of antibiotic program are conducted microbiology tests. The documents are prepared by by order of the director of the hospital, Committee of Drug Policy, and approved by him. The control implementation in the hospital is carried out by the Commission of Drug Policy, hospital epidemiologists, and microbiologists. External control is exercised by regional health inspection. As an example, to appropriate antibacterial therapy would give the following case. A patient with a history an infections pathology enters the hospital, starting empirical therapy according to defined rules of the localization and infection, and take appropriate material for microbiological examination. After isolation of the causative bacteria in changes according to the treatment, shift a sensitive and isolated microorganism. So many important steps: reconciliations, empirical therapy, material for study, pathogen with a specific sensitivity, connecting with the clinician, discussion and switching according to study, relationship clinician, pharmacy. Scaling of new therapy, very important. This involves a full process of collecting data on the antibiotic with the participation of all levels and forms and communication, very good communication, physicians, patients, microbiologists, doctor pharmacists, doctor nurses, and verification and electronic orders, and results from therapy, dosage, duration, and pathology, as a result of which it is important to change the mode of the replacement time, the antibiotic. Thank you very much for attention.
Thank you very much, Milena, for joining us from Bulgaria and bringing this Bulgarian case study to our colleagues who are currently following. I think we are with more or less 60 participants following this webinar, and it is very important to have your example with us, having shared with us. Let me then take the freedom to move to the next speaker, and I'm very happy, Giulietta, that you could join us and represent the voice of the patients. I think it's very important, and I would again express my gratitude to the European Patient Forum and Christina and her team to help us in bringing the speakers together, and also in working in the joint action on the analysis of the medication reconciliation and other topics. So again, thank you so much. Giulietta, the floor is yours.
Thank you for having this opportunity for this presentation. Beside my paid job, I work as a volunteer as a patient representative for national or European organizations like, for example, European Patient Forum. What is medication reconciliation exactly? It is a way of identifying the most accurate list of all medications that the patient is taking by comparing them to the medical record to an external list of medications from a patient, hospital, or other provider. It is a solution, or should be a solution, to well-documented patient safety problem and unintentionally introducing changes in patients' medication regimens and preventing incomplete or inaccurate medication information of transitions in care. Next slide, please. I would like to share some personal examples, some negative and positive examples of medication reconciliation. For example, my father has a heart conditioning and he's using heart medication and has experienced side effects. Instead of telling his physician, he tells me because he thinks he should not complain about his medication. Luckily, as a person with asthma myself, I can call anytime my nurse if I have some side effects or if I have any questions or complaints about my medication. I can call anytime in between appointments. I have asthma myself and annually a spirometry is performed. Every year I ask for printed results, but unfortunately it was given me only once because they say it's not according to our guidelines to give printed results. Of course, patients should have easily access to their own medical record. Unfortunately, it is not always the case. When I traveled by plane in the past, I've asked my pharmacist about a medication list for a medication passport. It has happened that it was not up to date and the wrong medication was on the list. Luckily, my current pharmacist double checks and verifies my medication to keep my medication list up to date. Next slide, please. Insufficient medication registration happens in 80% of all discharge letters. Missing medication on discharge prescription leads to 50% of the errors in discharge medication. Incomplete medication list at admission leads up to 27% of prescription errors in hospital. Patients, general practitioners and pharmacists provide different medication lists in 70% of the cases. Next slide, please. So what is an actual medication list? All prescribed, dispensed, administered and used medications should on the list, including dosage, route, period of use, including early termination or change of medication, the indication of prescribing, the use of drugs or alcohol, and if patient has allergies, intolerances and contraindications. Next slide, please. Physicians, nurses, pharmacists, healthcare providers, they have a responsibility in creating an actual medication list, whether it is prescribing, process delivering, or administer the medication. But patients themselves, they really have a responsibility as well. Next slide, please. And we should focus on that as well. They should know they have the right to inspect and to obtain copies of their own medical record, and they have the sole right to authorize others to inspect, retrieve, use and updating of medical records. Focus on they have to give all information about a health condition that is relevant for care, and they provide their information about actual use of alcohol, drugs and prescribed medication. They may have a legal representative. They have, for example, difficulties with reading or to understand the information. Next slide, please. So what do patients need to perform their role in creating an actual medication list? They should know about their role in medication reconciliation. We should focus on public awareness campaigns like posters or brochures, TV or radio ads, social media or the use of websites. Patients want to be actively involved in the whole process of treatment, and we should focus on to reinforce the benefits for the patient. Patients should feel empowered and confident about providing their information to healthcare professionals. We should focus on the empowerment of patients and training healthcare professionals on how to communicate well with patients. They should have easily access to their own medical record and the easy way of collecting their own medication data. I would like to give you an example of what has been created in the Netherlands. It was an initiative of the Netherlands Patient Consumer Federation. Next slide, please. They have developed patient information cards, a communication tool for healthcare professionals and patients to support the safety of the treatment. It's easily downloadable from a website, and many different patient information cards are created. There's a search option as well. There are different patient information cards about all care situations and providers in healthcare. It's easily accessible, and there even are some possibilities to create their own patient information card. It is a guide for healthcare providers and patients. Next slide, please. I want to thank you for your attention. If you have some questions, please let me know. I've here my contact, my address, my email address as well. Thank you.
Thank you so much, Juliette, for sharing the patient perspective with all of us. And I'm sure that after the last presentation, which we will have now, we will open the floor to the audience. So I am asking the audience to prepare yourself for starting the dialogue with the speakers, and so we can move that area forward. But before that, I would like to give Hannele the floor for a best practice from Finland. Please go ahead.
Thank you so much for your kind invitation and the possibility to tell how medication reconciliation is taken into account in nurse prescribing education in Finland. First, nurse prescribers graduated on May 2012, so it's quite new in Finland. And in fact, this afternoon, 21 students will get their certification in our university. So we have celebration day today. First, something about nurse prescribers education. The pharmacological studies are exactly same as in medical education. So in my opinion, nurse prescribers are very aware of patients' different medicines and their influences. They have good abilities to assess the medication. Then, during studies, each student has to make own risk evaluation assignment where they are describing and thinking their own responsibility as a role as a nurse prescriber, and they make own medication risk charting, thinking about what kind of errors can be possible in their work and how they could avoid those errors. Then those students who are highly experienced nurses working in primary health care write 12 case diaries under the guidance of certificated physician. And there they describe very carefully, using EBM guidelines and so on, databases, history taking, including best possible medication history. They make status and conclusions. Then they write down pharmacological therapy, patient's current medication, and medications to be prescribed. And they describe need of drug therapy, dosages, duration, effectiveness, interactions, adverse effects, side effects, follow-up of medication if needed, and then they are training to make prescriptions. And of course, part of those diaries is to make very careful documentation and also write down how they counsel patient, and then they make self-evaluation. Okay. In the work, nurses are able to prescribe when the need of care is assessed on nurse's practice and nurse has examined the patient. So it's not possible to prescribe anything without meeting a patient and interviewing him or her very carefully. And it's very easy to make that complete evaluation of drug therapy when you meet patient and you can make very careful history taking. And as well, nurse's appointment is very good situation to give counseling concerning of medication. And then on the nurse's appointment, nurse must have a possibility to consult physician if nurse is unsure in decision making, or if the nurse has no right to start or continue medication which is needed. And a nurse is not allowed to end regular medication without consulting the physician. Next. Okay. Nurse must follow patient's written care plan and instructions of healthcare unit, which are based on national treatment guidelines and national nurses medicine list. In Finland, at the moment, the right to prescribe is limited. It's limited in certain diseases, in certain medicines, and in certain organizations. It's only possible in primary health care, and the diseases are certain general infections, which nurse can start medication, and nurse can continue medication in high blood pressure, asthma, diabetes, and so on. Nurses have electronic databases which support decision making, for example, EBM guidelines and ThingsFaro interaction database. We have electronic documentation, and all those databases are very easily linked to that electronic database. In their work, nurses report medicine errors very systematically. And before nurse can have that right to prescribe, nurse must have a written assignment specifying the medicines that are allowed to prescribe and possible limitation. The right is given by the physician in charge at the health center where the nurse is employed. Okay, and in conclusion, the nurse prescriber, and especially in nurses' appointments in health centers. Nurse can assess the need of drug therapy on nurse's practice. He can make the prescription based on effective drug ingredients, strength, and form of the drug. Today, it's not possible to make a prescription with brand name. Then nurse assesses effectiveness of drug and makes an announcement of adverse and side effects if needed. Nurse is able to renew a prescription according to patient's care plan, which is written by physician. Nurse updates patient's medication list and assesses patient's regular medication in wholeness. And in my opinion, nurse has very good possibility to monitor if patient takes one's medication as prescribed or not, because very many follow-ups, for example, diabetics, hypertonia patients, asthma patients, and so on, are in nurses' appointment. So they meet patients several times in the year. And the new role of nurses may also enhance patients' adherence to medication therapy and on treatment, which is sometimes very weak, especially in long term in chronic illnesses. Next, please. Okay, and here is some statistics about most common prescriptions and diagnoses from the first year. From first year, nurses wrote 3,310 prescriptions. It's not very much. It's about the 100th part of all prescriptions made in Finland. But as you see, the most common drugs prescribed are antibiotics. They are short antibiotic courses, and the most useful, most common diagnosis is urinary infection. About half prescriptions are for urinary infections. Then pharyngitis, tonsillitis is the next one. Nurses have right to prescribe phenoxymethylpenicillinum for that kind of infection. And then nurses wrote quite much metformin for diabetics and simvastatin for hypercholesterolemia. The hypertonia is very common diagnosis, and nurses have right to prescribe beta blockers, ACE inhibitors, and diuretics. But because they have 3 different kind of possibilities to write prescription, those medicines are not very high in the list here in most common prescriptions. Thank you for your attention.
Thank you very much, Hanneli, for sharing the Finnish best practice, and congratulations on your celebration today, and send at least my regards to all the nurses who are graduating today. I think they are entering a new world where many, many nurses in Europe could learn from and could be inspired from. So congratulations again.
Thank you so much.
Be welcome, be welcome. I would now like to hand over to my colleague Sylvia, who will lead the discussion with the audience. Sylvia, the floor is yours.
Thank you. Thank you all the speakers and participants first for being here and then for your great experiences. I have noted that Christina from the Medical Students Association would like to raise a question to Stephanie. Christina, do you hear us?
Hello there, can you hear me?
Yes, very good.
First and foremost, with regards from European Medical Students Association, I would like to thank you very much for the opportunity to join in this webinar. Now considering my question, I loved the example that Ms. Tohill has friendly shared with us about the electronic solution for medication reconciliation introduced in the UK, especially the part about how patient receives immediate discharge summary to bring to the GP. As I do realize that it is a very efficient way of doing things in the UK, but what happens if the patient is not a citizen from the UK? Well, the physician or a GP from another EU member state will have an access to that form. As Ms. Harris in her presentation stated that this actually currently a big issue in the Eastern European wing. And then the other part of my question would be when I go back to Lithuania from Brussels, when I finish my term as a permanent officer and become a physician, how would I implement the system like you did in the UK? So yes, thank you very much.
Hello. Currently, as well as it being electronically, we do also print it out for the patient, so it would be that particular case we would have it printed out including the medication list as well as the doctor's notes as to what has occurred during the patient's stay, and that is also given to the patient. At the minute for the paper records, so we're not fully electronically, we're partially paper. So in that case, the patient would actually get a paper copy of everything. There is no electronic link, unfortunately, at the minute for other European member states. Ideally, yes, we would like full electronic records, and that's a process that's being looked at and piloted at the minute, but not just yet. So it would be printed out and given to the patients for them then to bring to their healthcare provider in their own home. Your second part of your question, just remind me what it was again, sorry.
The second part about the implementation of the system. How do you implement this? If I, for example, I'm originally from Lithuania, and I go back to practice as a GP, and if I want the system to happen, what do I do? What are the actions?
Yeah, I suppose for us we have piloted it and rolled it out slowly at the start, and then it has been rolled out throughout our old trust. Ideally, we would love to roll it out throughout Northern Ireland, but that's not the case at the minute. So we started quite slowly just to ensure it worked well. And then
when you would have the registration list, or at least the draft list started.
We can Monday, no, because
excuse me, participants, can you?
So I would say by Wednesday morning.
Hello.
I think they asked me already at the beginning.
Am I? Hello.
Well, to be on Tuesday, but to be honest,
many people start talking.
I'm really busy with the questionnaires and everything.
In the webinar. No.
Anna Marie?
Yes, Anna Maria, please say to your colleague that we're hearing everything. So, no, just a reminder, kindly reminder to all participants, please unmute yourself and be careful because we can, if you're speaking or taking the phone, we can hear you and it's interfering all the other communication. Stephanie, please go ahead.
Sorry, what I was basically saying is we have rolled out very slowly, so we were able to change it slightly if needed to and then we have rolled it out completely to our trust. And ideally, we would love to roll it out to the whole of Northern Ireland and then further. So it is a slow process initially to roll it out, and then it just once we had started to roll out, it went quickly after that. So it's completely rolled out in our whole trust. I suppose ideas as to how to roll it out further would be great as well.
Thank you very much. I have also noted that Josipa from Croatia, she is sharing a kind of the same experience that our Romanian colleague, Dr. Monica Haras, has been sharing with us. Josipa, would you like to comment something?
Yes. Can you hear me?
Go ahead, perfectly.
Okay, I work also in medical rehabilitation, and we also have the same problems like Monica. So we have patients that came from their houses, not directly from the hospital. So they take different kind of drugs. They get to different kind of specialists, and they come to our hospital without their drugs from the home. So we need to check what they take and to call their doctors, to call their nurses, and to check what they need to have by in our house. So sometimes we have problems with that.
Thank you very much, Josipa. Thank you.
How you solve that problems in your house?
Monica, would you like to reply to Josipa? Monica?
Yes, I'm here. Can you hear me?
Very well.
How do we solve the problem? We communicate a lot with the patient and his or her family. We write down, we have written charts, electronic charts, and previous medication is carefully written down in the written chart, solid chart of the patient. If the patient doesn't know previous doses, that's it. If we have something, a note, a prescription, a discharge note written by another doctor, we use that. And that's how we solve it. About patients coming from different locations, I had some difficulties with patients coming from France, not because I don't understand French. They had very nice, well-written discharge notes by our colleagues, but the medication was written by brand name and not by active substance name, and they have different brands on their market. So I had a lot of difficulties grasping the fact that the patient was meant to receive aspirin because they had this brand name that I've never heard of, and I had to look it up on the internet. So we're doing everything we can. We even look it up on the internet if the prescription comes from another country with different brand names. It is my idea that it would be nice for your organization to militate for discharge notes that contain active substance denomination and not brand names. That would make medication reconciliation much easier between countries.
Thank you very much, Monica. Thank you. I have also another question from Jamie Wilkinson. He would like to ask a question to Rai. Jamie, please go ahead.
Hello, everybody. First of all, thanks for a really nice webinar. It's been really interesting listening to all the presentations. If Ray is still online, I'd like to ask him a bit more about the interactive services initiative that he mentioned. So Ray, if you're there, would you be able to let me know what the name of the system is, please?
Yes, hi. This is Ray here. Can you guys hear me?
Yeah.
Okay. When you mean interactive surfaces, do you mean those smart surfaces where you saw in that picture?
Yes.
Okay. So what we call that is, so we have our R&D research centers looking into that, and they've been looking to that for a while now. We call that interaction, it's really three things that are driving that and what's going to make it real. One of it's cloud computing. So being able to have that information to appear in a place or on a device anywhere is a key driver. The other one is form factors. So the form factor that we're using now, or the majority of people are using now on the call, is their computer or their telephone. What you saw as that table, it's a form factor. It is a table that can interact with the internet. And then the last bit is called a natural user interface. So essentially, instead of typing on a keyboard, how do you get the information you want in something that's very natural for you? In this case, you're interacting with a table. So there are hardware partners and manufacturers that are also developing smart systems. So for example, we have our center in Brussels, and I hope if you haven't been there, please do come. We've taken a piece of glass and we've been able to project an image on a piece of glass, a regular piece of glass. And then we put a transparent touch foil on there, so you can move around your images by touching and interacting with that glass. So that's kind of the technology today. It wasn't, relatively speaking, it wasn't, incredibly expensive. It's probably more expensive than what a health worker or a nurse or someone could afford. But these prices and technologies, as they mature, will become cheaper, faster, and better. I don't know if that answers your question.
Yes, thanks for that, Ray. I was just wondering if there's a place where we can find out more information about the system.
Yeah, you know, what I could do is I could forward some of the research that we're involved in that either talks about these interactive surfaces, talks about, you know, the use of projection and, you know, these form factors. If that sounds okay, I can send it through the EFN to circulate amongst the group.
Yeah, if Paul's happy with that, lovely. Thank you.
Thank you
And if you have any questions, feel free, of course, to reach out to me.
Silvia, please, Jose from Spain, can I speak?
Yes, Jose Luis, wait a second because we have other people waiting for questions. If I can give the floor first to Joana Laura. She's a pharmaceutical student.
So it's about this question, but later, okay.
Yeah, thank you. Joanna.
Hello, everyone. Can you hear me?
Very well. Go ahead.
Oh, I'm Ioana Bogdan. I'm a pharmaceutical student in Romania, and I'm also working for the European Pharmaceutical Student Association. Thank you for the invitation, first of all. I really appreciate this initiative. My question is, how do you see that the collaboration between the physician, the clinical pharmacist, and the nurse can help to implement this system easier? I think that maybe their collaboration is one of the keys in order to increase the quality of patients' life. Thank you.
Thank you very much, Iona. Any of the speakers would like to take this question? Hanel, maybe that you are representing now and saying the nurse prescriber. Would you like to take this question?
Okay, I can say something.
Thank you.
Well, as I told, nurse prescribers must have the possibility to consult doctors, and I see that the collaboration is one of the key things when we are thinking about better medication reconciliation. And I know that when a nurse prescriber started in Finland, they also made very close collaboration with pharmacists, because it's very new in Finland, and of course ministry and so on looks very deeply and what we are doing, and can nurses write proper descriptions and so on. And I think medication reconciliation wouldn't manage without collaboration.
Thank you, Hanel. Juliet, maybe from the patient side, would you like to strengthen a bit the needed collaboration between the health professionals?
I'm sorry. Can you give the answer, the question again, please?
Yes. We had a question from a student, from a pharmaceutical student. She was saying, we need to collaborate among the professionals. How do we do it? What are our suggestions? What it is needed, it is not needed? And I think from a patient representative perspective would be good to have your experience a bit. You have been mentioning already some things, but maybe you can respond to Joanna on how do you see the collaboration among health professionals? What is needed?
I think open communication. You should focus on the elderly patients, because the younger patients themselves, they feel more empowered. Maybe we should look into what has been developed in European countries about patient empowerment. I think, opinion, it's to create an actual medication list. The patient should be involved, and they should be aware of there are really one of the keys to create an actual medication list. Yes, it's.
Thank you very much, Juliet. Thank you. Jose Luis, I know you wanted to ask a question, right?
No, I want to answer the two questions.
Very good, very good. Please go ahead.
Okay, in Spanish, please. La primera pregunta que se formuló era sobre el tema de las interacciones, si no me equivoco.
The first question asked was about interactions, if I'm not mistaken.
Y me gustaría comentar que nuestra plataforma de cuidados incorpora un sistema de vigilancia de interacciones de cualquier medicamento con cualquier medicamento y bajo las condiciones del paciente, es decir, tiene en cuenta la patología del paciente.
I would like to stress that our system, our platform, has an alert mechanism for any possible interaction between different drugs, taking into account the specific pathology of the patient.
De tal forma que advierte al profesional de cualquier iatrogenia, cualquier problema que surja cuando mezclamos medicamentos, porque tiene en cuenta sus interacciones con las condiciones del paciente.
So it warns the professional about any iatrogenia or side effects because it takes into account any possible mix of drugs that we make.
Esto quiero ligarlo con la pregunta última que se ha formulado sobre la intervención multidisciplinar, cómo hacerla factible, y me gustaría comentar que es importantísimo la incorporación de sistemas interoperables.
So I would like to link that issue with multidisciplinary collaboration, stressing also the importance of having interoperable systems.
Es decir, se trata de incorporar la historia clínica única para el paciente, donde cada profesional tiene que incorporar su información. No podemos tener múltiples historias.
So the issue is to have a single clinical history where each professional includes the relevant information. We cannot have different clinical records.
Y el paciente tampoco tiene que ser el correo entre profesionales para ir diciendo a cada profesional lo que le ha dicho el otro.
And patients should not be the messenger. That is, patients telling professionals what the other professionals have told them.
Tiene que empoderarse para poder tomar su medicación, pero no tiene que ser un instrumento de los profesionales sanitarios.
So the patient has to be empowered to take his or her medication, but the patient cannot be an instrument or a messenger for healthcare professionals.
Por lo tanto, estamos convencidos de que las administraciones tienen que facilitar a todos, pacientes y profesionales, sistemas únicos, interoperables, donde podamos recoger toda la historia clínica del paciente.
So administrations have to facilitate and to provide patients with unique, single and interoperable systems in order to gather all the information accurately.
Okay, thank you.
Thank you, José Luis. I have also a master student, Simon. I think you have also a question for José Luis. Can you hear us?
Yes, I can hear you. Can you hear me?
Yes.
Okay, perfect. Okay, so I'm Simone, and I'm a master student studying right now international health. But I did my bachelor's writing about an interoperable electronic health record system in Andalusia, and I came across the Deraya system. And I was just wondering, because it was like a year ago, I haven't unfortunately not followed up on the improvements of that. So I was just wondering, because I read that Deraya system is going from Andalusia is going to be implemented in the whole Spain. And I was just wondering if you have heard of that and if you think that it's something which is coming along the next years. Gracias.
Very good.
De nada.
Gracias por la pregunta. En España, para que todo el mundo conozca, tenemos 17 regiones y, por lo tanto, 17 sistemas sanitarios distribuidos por cada una de las regiones.
So, just to give you some background information, in Spain we have 17 regions, and that means that we have 17 different healthcare systems.
¿Esto qué quiere decir? Que cada región ha incorporado un sistema de información y en ocasiones un sistema informático para la recogida de su historia clínica.
This means that in many cases each administration has one information system and sometimes a different IT system than the rest of the autonomous communities of Spain.
Lo que decía esta estudiante, Andalucía es una de las regiones y tiene su propio sistema informático.
As the student rightly said, Andalusia is one of the regions of Spain and has its own IT system.
Que yo sepa y tenga conocimiento, no creo que sea el sistema de Andalucía el que se va a implantar en toda España. Les comentaré cómo se va a hacer.
As far as I know, the system in Andalusia is not the one that is going to be implemented throughout Spain, but I'll tell you the procedure.
Nuestro Ministerio de Salud lo que ha hecho ha sido desarrollar un proyecto para tener el mínimo de datos compartibles entre todas las regiones y también a nivel europeo.
Our Ministry of Health has developed a project in order to include a minimum data set for all Spanish regions as well as for the European Union.
De tal forma que cada región aportará el mínimo de datos que se ha coordinado ya en todo el país, pero no quiere decir que un sistema de una región se va a implantar en todo el país.
So each region will provide the minimum data set that has been agreed upon, but this does not mean that the system of any single region is going to be implemented in the rest of Spain.
Ese, si lo quieren buscar en internet a través del Ministerio, es la Historia Clínica Digital Única.
If you want to check it on the internet, it is called Historia Clínica Digital Única, which is a single healthcare clinical record.
Thank you very much. We have a question from Mora. Yolanda, are you still with us? Yolanda? Because, Mora, I think that you want to ask a bit of a question or a bit more information about the project itself, PaSQ, the Joint Action on Patient Safety and Quality of Care. We had the pleasure to have one of the work package leaders in this group. I don't know if she's still listening to us or not. But anyway, you can address your question. If she's here with us, I'm sure she will reply. If not, I will take it forward.
Silvia?
Yes, Yolanda?
I was muted by the system.
Very good. Listen, Mora is going to ask a question about PaSQ, and I would like you to take it forward. Okay?
Okay.
Mora, please go ahead.
Lena,
I don't know if she's here.
Lena, are you still with us?
Mora Guillem, are you here?
No.
Well, Yolanda, we have lost the question, let's say. But now that you are with us online, and I know that you are next to me, let's say virtually, I know that many Spanish organizations have been implementing medication reconciliation. Maybe you would like to make a comment on the presentation that have been shared.
Thank you, Silvia, for this opportunity. Well, in fact, and thank you very much for all the presentations and this webinar. But in fact, Mara and Silvia, another Silvia here, and me were following this presentation. And well, we were a little surprised because we have well, maybe we didn't know well the objectives of this webinar because we expected that we're more oriented to specifically medication reconciliation. We didn't expect a presentation regarding technology like Microsoft organization or maybe some specific care plans for from nurses. But I mean, it's fine. So, but finally, I think the webinar was centered at the end, and I think it is a very good opportunity to say that these webinars are mainly oriented to the coordinators, to the leaders at the organizational level, in order to improve the implementation of these practices that already is implemented in some need to know specific examples to improve this implementation. So I think it was useful to participate in this webinar. So I don't know if you want another input from us, Silvia.
Mora, I think you have been muted, and now we can hear you probably. Can it be? Mora Guillén? I think she has a problem. Yolanda, thank you very much for sharing your thoughts. I think we had a question, but if we receive it, I will let you know.
Hi, Silvia. Can you hear me again?
Yes.
Yes?
Yes.
Silvia?
Yes, but maybe you cannot hear us.
Yeah, I can hear. Did you hear this thing that I said?
Yes,
yeah,
absolutely.
Absolutely.
Okay, if you want another input from us, I don't know if I properly answered your question.
Yes, absolutely, Yolanda. Thank you very much.
Thank you.
Joanna, would you like to come in with another thing?
No.
Okay. Because I have been trying to follow in, you have been written in, participants who have been written some questions. I have been trying to follow all of them. I think I have taken all participants. I don't know if somebody else would like to make any comments.
Silvia?
Yes?
I'm sorry, I think the system doesn't like my voice because I'm muted all the time. Sorry. So I don't have to say anything else. Thank you very much.
Okay, thank you, Yolanda.
Hello.
Yes?
Sorry, Sylvia, it's Stephanie Tuchel again. I was going to say, for our MedReg process that we do, the patient is the key, because they are the one person or care that would know the medication the most. So we use the patient as our primary source of information, and then we also use the general practitioners list and community pharmacy or other, maybe if they've been to other hospitals, information for that. But what I suppose I didn't stress is the information that we gather. It does on discharge go into a single patient electronic care record that can be accessed by all the healthcare providers. So, and that's regional wide for Northern Ireland. So whilst our own system is within the Northern Trust, the information that we output, whilst we do print it out for the patients as well, it does go into this electronic care record for the patients, so it can be accessed easily by other healthcare providers regional wide.
Thank you, Stephanie. I think we have a last question from Simone. Please go ahead.
Yes. Hi. Sorry for the last question. I just wrote it down. So because right now I'm doing an e-health course at Luleå University in Sweden, and we have to do our own project about e-health, or like an e-health project. And I would like to get your opinion on what you think of my project, because I have to present it on Monday. And it will be about an integrative electronic medication administration record system that is linked with an RFID and the electronic health record system to the hospital storage management to increase patient safety and decrease medication error. And do you think this is possible to implement? It's quite a long title, I think, but so the main point is that it's going to decrease medication error and to increase patient safety. So I thought maybe why not ask you when I have you here.
Thank you very much, Simone. Is any of the speakers willing to respond?
Sylvia, I can try to just take a crack at that.
Go ahead,
it's hard to analyze the answer without seeing the solution. And just hearing the title, if it's RFID tagging, there's pros and cons of using it. And, what are you RFID tagging? Is it, I struggle to see what exactly you're doing with the medication so that you would be able to understand, the consumption. You could use, as the example I showed with the bottle, so that they will understand, they could see how it's being used and interacted with. So depending the technical setup you have. I think in theory, yes, and it should definitely, if thought out properly, suit its purposes. But you just have to go quite deep into the technical solution to make sure that functions properly and test it and retest it.
So my thought was, well, once the patient is coming to the hospital, he normally gets this barcode tag, like this wrist tag, for example.
Yeah.
And what maybe could do, I mean, this is a theoretical project, and I'm just writing it as a 7.5 credit course, so nothing fancy. But it would be then that the RFID code will be in the tag for the patient, and then the nurse or the healthcare professional can scan with the RFID scanner this code, and then transfer it to the electronic health record system, electronic health record of the patient.
Yeah.
And then they see what the patient needs for medication.
Right.
And then, of course, there's the administration of the medication, and at the same time, this will be the satellite for the storage facility, so that they can directly have a real-time measurement of inventory in hospitals, because I know in several countries this is, or rather in low-income countries now, but
So
there's a problem.
So I understand a lot clearer, and the simple answer is yes. And I'll give you a very simple solution. We just did an event about a week ago where everyone had a badge with a tag on it. If you just put your phone up to that tag, you get all the background information that the person wanted to share, of course, straight up on your phone. You know the details, what the person did, et cetera, stored in your phone, et cetera. I mean, if you could do that for a simple event, I think you can do it. As long as the patient agrees and you meet privacy compliance rules, it would definitely be possible.
Yeah, and then
sounds like a simple solution and cheap.
And then the second question for that would be, what do you think can be empowered, and how far can the empowerment for the patient be applied? Because that's the thing, I'm a bit stuck, and it's one of the requirements for the course, and I don't really know. And if you have an idea, I would be highly appreciating this.
I missed the question. I'm sorry. You cut out.
What do you think can empowerment? How far can empowerment for the patient be applied in this project?
Maybe we should have an offline discussion, because that sounds like a quite a deep discussion there. I mean, I think essentially what the solution, if I understand it correctly, is you want information to be shared very quickly between the health worker and the patient in an environment where you don't have a lot of money to spend for complex IT solutions. So very simple RFID tagging, telephone infrastructure, device infrastructure, internet. You'd be able to get things done quickly. I think you could. So I think we talked about what could the health worker benefit from. I think in regards to the patient empowerment, they would be able to understand themselves, to access the information. I think in my earlier presentation, all you need is some kind of interface that they could interpret the data. So if it's data that nurses can read, it's not necessarily data that patients can read. So as long as you have that kind of interface, then I think the patient can really understand what that means.
That's something I can work with. That's perfect. Thank you very much.
Thank you very much. Thank you very much, Ryan, Simone. Thank you to all the participants. Thank you to all the speakers. I think we have here two major important things we have been talking about: the awareness on health professionals about the really importance about medication reconciliation, and the need to focus also on patient empowerment and how patients can take a major role also in focusing on their medication and communicating with the health professionals. We have been seeing with your experiences and your examples that there are many different situations where the patients are moving, citizens are moving, we change of units, we change of professionals, but there should be a continuing line of communication, and for that thing we still have a way forward. There is important to have an interdisciplinarity when we are tackling medication reconciliation, because there is a shared responsibility. So I think in the context of PaSQ, that is the Joint Action on Patient Safety and Quality of Care, We will be doing some more activities. Our colleagues from Spain, Yolanda, thanks for raising also the issue. We will be implementing, and I think this type of webinars are raising awareness of how the situation could be tackled with different experiences. But this kind of project and this network that PaSQ is creating will help supporting this exchange of experiences that we find extremely interesting. I will just give the floor to Paul to close.
Thank you very much. There are still 35 people with us, so congratulations to stay with us for 2 hours. And I really hope that this small exchange of views is a little bit thinking out of the traditional box. I get the feeling that we have gone beyond the scope of the traditional thinking, and I really hope that this will help us providing input in the coming year to some EU presidency meetings. Now we're going to Greece, then we're moving to the Italian presidency, for then going to the Latvian presidency. And there are many challenges, and I really hope that medication reconciliation is one of the topics in elderly care and other sectors which you, with the experience, can take up in whatever format in relation to the European Parliament, in relation to the European Commission and your Council of Ministers. This is a practical issue, but we still have to work harder to make it better in the system. So this is a kickoff, this is a start of ideas. We have also the connection with the data that we collected in PaSQ, and this gives other views. So putting that all together, perhaps we can at least influence the political agenda on this topic, very important topic. So thank you so much for sharing your views with us, and thanking the audience for intervening and for questioning. So I wish you all the best. Thank you so much.